Hello, everyone. Welcome to another episode on Oral Pathology Tuesdays. It's a very interesting topic today. Have you ever thought that, rather, I should say, you probably think that the brain is one of the fastest working organs and one of the most agile? Of course, that's what we think because of the amount of glucose it uses. It should be agile. But in reality, that's quite not so. In fact, our brains are quite lazy and will choose to do the least amount of work possible at any time until we specifically nudge them into doing more work. So, this is exactly what we are going to talk about today because, of course, when you make the easy choice, you look at a lesion and there is almost immediately the thought or a picture comes to your mind and you say, oh, this is it, without thinking of the rest of the picture, the clinical findings, any other additional findings, and you are now fixated on your diagnosis. This, of course, as most of us know, can lead to a lot of problems. Now, the difference is when you think fast, that immediate thought is your brain being lazy. The idea is we try and get it to do the extra work. And how do we about doing that is what we are going to be talking about today. But before we do that, let me share some interesting news with all of you. And so we have here the, yes, we're very happy to tell you that we have our membership now for the channel. And of course, I will tell you more about it later on in the lecture. I don't want to take much more time right now. So let's bring in our guest today. We have with us Professor Ruben, and many of you, of course, know him. He is attached to Raga's Dental College and Hospital, Chennai. Among his many interests is innovative medical education and the ways to do it, which is part of the reason we have today's topic. His academic excellence, multitude of publications are recognized, and he has even received international prestigious awards for some. I can see that at the moment he is lost his connection, but don't worry, we will listen to his lecture and then we will come back, and by which time we shall also have him back here. So let's go watch the lecture and come.
At the outset, I would thank the management of the Raga's College and Hospital, Chennai, my teacher and head of the Department of Oral Pathology, Professor Dr. Ranganathan, my Dr. Elizabeth, Dr. Uma, for helping me and molding me to be what I am today. The topic is diagnostic errors in the head and neck region, understanding the neurocognitive basis. As you know that when a patient experiences a dental or a oral problem, the patient engages with the system wherein all informations are gathered by the physician and the information integration and interpretation happens and the working diagnosis is done. This includes clinical history, physical examination, diagnostic testings, imagings, histopathology, and suitable referrals and consultations are done. And a diagnosis is made and it is communicated to the stakeholders, be it the insurance, companies, or whatever, maybe even the patient themselves. And informed decision is taken and treatment is executed. And this is the regular stakeholders. And wherein the failures in the diagnostics process could occur is at the level of engagement, when the patient comes, when the information is gathered by the surgeon or the physician, and information is integrated, when it is interpreted and establishing an explanation for a problem or a working diagnosis, as we call it. And when there is a communicating this diagnosis or the explanation to the patient, these are the stages where a problem could happen. So what is the definition of a diagnostic error? The diagnostic error is an assignment of a pathological or a radiological diagnosis that does not represent the true nature of a disease in a patient. So I want you to introduce to few terms before we embark on this discussion. What is a bias? Bias is an unfair support or opposition due to personal opinion. This refers to cognitive biases in this presentation that can influence a clinician judgment. These biases can lead to systematic errors in decision making. For example, a clinician might favor treatments that are more familiar with to him or more beneficial to him, even if evidence suggests the other treatment might be more effective, and that is bias for you. Cognition. It is the mental process of acquiring and understanding knowledge through thought, experience, and using senses. In clinical decision making, cognition involves gathering patient information, analyzing, and making decisions based on the information. Metacognition is the ability to monitor and regulate one's own thinking while engaging in the process of diagnostic reasoning. It allows clinicians to identify limitations in the quality of information obtained, inconsistency, explaining inconsistencies or unexpected findings, and that is metacognition for you. Now introducing a very complex term called as heuristic, which is a way of solving problems learned by oneself, which cannot be explained. It is a process of making decisions quickly and easily. It is like a shortcut that your brain, I stress your brain, it is customized. Your brain uses to save time and energy. They are mental shortcuts or rules of thumb that you subconsciously follow. And they are used by clinicians to make decisions quickly and efficiently. Your pattern, your Swiss cheese, or your soap bubble appearances in radiology. All these are patterns which you employ subconsciously, and that is termed as heuristic. I introduce a term called as mindfulness, which is a moment by moment awareness of thoughts of your own self, or maybe feeling, sensation, or environment. In clinical decision making, mindfulness refers to being present and conscious of one's thoughts, the logical, the analytical feeling, bodily sensations, and surrounding environment, which allows for early identification of decisions that need to be made and is useful or creative in problem solving and more through ethical evaluation. Thinking refers to the cognitive process used in reasoning and making decisions. It involves both fast thinking and slow thinking. So what is this mean? Hypothetic deductive reasoning is a method where hypothesis or a diagnosis is formulated based on observations. Deductions are made from this hypothesis and observation. In clinical decision making, this could involve forming a diagnosis or a hypothesis about a patient condition based on their signs and symptoms, then testing the hypothesis using investigations to arrive at a diagnosis. Dual processing theory suggests that the clinicians use two systems of thoughts when making a diagnosis or a decision. System 1 is a fast, automatic, emotional, subconscious way, which I call it as atomicity, and system 2, which is a slow, deliberate, conscious effort systems. Both the systems work together to enable effective clinical diagnosis. Rational override is a intentional friction created subconsciously influencing behavior by activating reflective conscious or subconscious thinking. It is not a standard term in clinical decision making literature, but could refer to the use of rational thought, your system 2 kind of thought, to override an intuitive initial judgment, that is system 1, which might occur due to the conscious effort of the clinicians, meaning you put in your experience, your conscious, your knowledge, your intelligence into action. While the disrationalia override is the inability to think or act rationally despite possessing adequate intelligence, possessing competence. And from cognitive psychology, it refers to the inability to think and behave rationally despite possessing competence or adequate intelligence. So what are the fallacies about the bias and errors? Here, people think that it is more of an ethical issues that can happen to incompetent or unethical persons. By the term ethical here, I include ethical, legal, and moral. So it is our belief that we are not coming under this because we are ethical. We assume that we are ethical, legal, and morally correct. And we believe that this is only for bad apples, or incompetent people, or experts who do not know their job. We think that we are an expert. We assume the Dunning-Kruger effect. We assume to be very expert in this field, and we expect an expert immunity. We believe that as experts, we are impartial and not affected by bias. That is a fallacy. Technological process. This is more of a radiology. We believe that the mistakes we commit are inherent to the technology and not to us. We blame the technology. The histopathologists blame the slide making process, the automation, the artificial intelligence that we employ. And we hide behind this bias, this process, and get ourselves immune from the human biases, blind spots. We believe that the other experts are affected by biases, but not ourselves. We firmly believe that we are not biased. That is a blind spot. And we believe that we have the illusion, or we have the control, but that is an illusion of control. We believe that the bias could impact me, but you have a strong belief that my experience or knowledge will be counteractive to these biases. I can overcome these biases by my willpower, by my intelligence. These are the fallacies. Where does this bias stem from? It could be category a case specific, or the environment, culture, and experience that you are grown in, or it is an inherent human natures, human and cognitive features which you are built in, your brain way of thinking, your personal factors, your grooming, your education, training, your organizational factors where you're working, their rules and regulations, the equipment they give, the base rate at which your entire system functions, your clinic functions. And the case specifics or the contextual information where the entire process of diagnosis happens, the reference materials that you're exposed to, and basically, more important, the case factors. The possible outcomes of a diagnostic error could be concordance, where you match with the original diagnosis or a proper diagnosis and your diagnosis. Minor discordance, just a slip away, but that does not affect the patient outcomes. Major discordance is when the actual diagnosis from your diagnosis is different, and that has a direct bearing on the treatment outcome. Histopathological errors could be classified as pre-analytical errors that occurs before the diagnostic process and involves improper handling of tissue samples, fixation, contamination, or loss of error processing. Mistakes. Analytical errors occurs during the diagnostic process, maybe due to technical issues with staining, imaging, misinterpretation, etc., or improper reading of the slides. And the post-analytical errors occurs after the diagnostic process while reporting or communicating or even typing of the results. Cognitive errors, which is a basis of what we talk today, occurs due to cognitive bias or your own heuristics, what we discussed earlier. It could stem from your own confidence or different types of cognitive biases, such as anchoring biases, where you rely too heavily on one certain piece of information, availability bias, relying on immediate examples or immediate cases that you saw, and a lot of other examples that we see in this presentation. Or this could be stemming from system errors, which is the flaw in the system, your healthcare system, could be emanating from lack of resources, inadequate training, and poor quality control. Here, we are concerned about the competencies, which is a basis of what we are discussing with the National Dental Commission's new education policies and upgradation of your competencies. The Western world has evolved competencies for oral pathology and oral radiology long back, but that is in the initial infancy in India. And probably when we are talking about the competency-based outcomes, probably we have to inbuild systems to avoid these diagnostic errors. In radiology, the diagnostic error could be interpretive errors, where the finding is identified, but you make a wrong conclusion, which stems from cognitive bias or decision errors or insufficient clinical information or workplace factors, which are external factors. The other is perceptual factors, where you fail to identify the finding or failure to see errors, which can emanate from technical issues, competencies, overlaps of or imaging faults or misinterpretations, which again stems from incompetencies. Jeffrey or Norman points out, if there is a science of error reduction, it is in its infancy, and we have very far to go even for Western world. In India, it is infancy, and the goal of my presentation is to avoid or develop a system wherein you inbuilt levels of checkpoints so that you avoid these errors, especially the cognitive biases and diagnostic error reductions. In a study by Peck et al. In 2018, in head and neck oral specimens involving about 11 cases, there was a minor disconsonance of about 3% and a major disconsonance of 7%. And in a sample size of about more than 250 pathologists reporting, head and neck samples had a major regional participants, that is rural, of 8% disconsonance, and from metropolitan 7%, meaning about 80 to the region does not play an important role, but the diagnosis plays. The study further reports that lesions like necrotizing myelometaplasia had a major discordance among the 150 or 250 plus pathologists who diagnosed these cases, and a minor discordance of 5%. Whereas for serious lesions such as metastatic squamous cell carcinoma and thyroid carcinoma, major discordance of 18%. Together put and see, about 1 in 5 cases had a major discordance, and about 1 in 20 cases had a minor discordance. That means people tend to have a misdiagnosis 1 in 5 times, which is huge impact on the patient. Either over treatment or under treatment could be done based upon the condition. In another study, Shishu Sinhara et al. Very recently, wherein the role of secondary diagnosis or secondary opinion was sought. This study had a drawback of not declaring the number of cases, but still, of these cases that were sent to second opinion, 4 cases had agreement, or 12 cases had to undergo a change in diagnosis. 6 cases had minor discrepancy, and 8 cases had major discrepancies. So 12 plus 8, 20 of this little sample had major discrepancy. Remind you, this is a second opinion study, and the outcome has to be properly interpreted. But it does not fail to highlight that discrepancy is there. The imaging error incidence in an about 2.8 lakh cases, they had 74 misses, of which 85 were perceptual and 15% were interpretive. And the most common places were face, orbit, central neck, lateral neck. And the clinical significant error involved aerodigestive orbit, masseter, and parotid glands area. And half of it involved malignant or potentially malignant masses, something a cause of concern in radiology. So now moving on to understanding the brain process to help to arrive at a diagnosis. When the patient presents with a chief complaint, the physician or the surgeon gather data, makes a diagnosis, generate a hypothesis, and search for the features that match the diagnosis, be it radiology, be it pathology. And what are the theories? There are a number of theories right from 1960s. A lot of theories has been postulated, and very recent theories are the dual processing theory proposed by Dawson, promoted by Croskery and Evans, and that is more involving. For that, I draw your attention to 2 important theories, that is pattern recognition and dual processing theory. Dual processing theory is very recent, but involves pattern recognition also, and that is what we are going to discuss today. This says that there are 2 theories, dual theory, 2 theories. System 1 is an intuitive, efficient, and based on pattern recognition. It is employed to be very quick and explicitly does not recognize as a distinct cognition, nothing of mind, no application of mind. Whereas system 2 is an analytic, cognitive application of mind that involves time and a conscious, explicit approach analytical approach to arrive at a correct diagnosis. So what is this intuitive thinking? Is based on treatment planning and can happen in exams also. And this process, microseconds. The style is heuristic. That is, you, by your experience, by your learning, develop a method, your own method for solving the problem. And it is mostly pattern recognition, both in radiology as well as histopathology. Mind you, the snow-driven appearance, the Swiss cheese pattern, the India filing pattern, or soap bubble like appearance, lazy gang rings. All these are heuristic patterns wherein the cognitive awareness is low, the cost of your brain energy is low, automaticity is high, the rate of function is very fast, but low reliability, and it is error prone. The effort, conscious effort is low in this intuitive thinking, but predictive power is also low, and the emotional component is high. The scientific rigor invested in this process is also low, whereas the analytical thinking also happen in this, but it is time consuming, and it is an analytical process or a systematic process happens. The cognition is high, the cost involved in terms of brain power is high, automaticity is low, the rate is also low, so slow process, but reliability is high. Errors are few, effort, conscious effort is high, the predictive power is also high, and the emotional component is low. You don't allow emotion to come into this diagnosis, but scientific rigor, it can withstand the test of science. So this is a comparison. I want to throw into the scientific level for intuitive, low, heuristic learning, whereas system 2 is systematic, scientific rigor is high. And the errors are more with intuitive, while less with analytical. Let us put a dental. Type 1 system, knowledge failure. The student does not know, it is competency, it is knowledge. Whereas type 2 knowledge failure, the student knows, cannot access. The student has knowledge about the pain in pulp, the tooth anatomy, periapical pathosis, all cardinal signs of dental caries, inflammation, everything. But he fails to put together how the unique pulp autonomy, the evolution of periapical pathosis and dental caries, the role of inflammatory mediators, the swelling, the pain, to elicit the history or understand the process of evolution of pain in teeth, so that he makes a working diagnosis, whether it is acute pulpitis, chronic pulpitis, or periapical pathology, so that he can frame an appropriate diagnosis. So this is incompetency, whereas this is the failure that we are talking about. So a basic questions: are diagnostic errors result of cognitive factors or knowledge deficit? For a cognitive, if it were a cognitive influence, there is no relationship between increasing knowledge, experience, or errors. Meaning, even a well-experienced, well-reputed person with sufficient or a great knowledge can make mistakes. Then it is not a knowledge deficit, but a cognitive influence. Here, it is more of a type 2 analytical processing and error. It is a systematic error, and it can be corrected only by addressing the bias explicitly, reworking, recalibration. Whereas if it were a knowledge deficit, with experience, you will learn more. You will be more or having more knowledge and reduce errors. Experience is a best teacher. This will address the type 1 processing kind of approach. It corrects the type 1 processing intuitive expertise, speeded task, distraction, automaticity. A patient walks with a cancer. The first question is your tobacco usage, because we believe that tobacco is the main cause of cancer. But mind you, 1/4 of the cases are not tobacco associated. So this knowledge deficit comes with experience. The greater the experience, lesser the type 1 processing errors. So the cognitive influence as well as the knowledge deficit is there. So how to avoid both? Knowledge deficit can be avoided by increasing competencies, whereas cognitive influence, you have to avoid the bias. Mind you, if I are teaching and no one is learning in the process, you are just talking. How do you export experts approach to solving a problem? by using pathognomonic signs and symptoms. If you are using a pattern recognition, like I said, Swiss cheese pattern, soap bubble appearance, then you are employing a non-analytic or an intuitive approach. Whereas if you are reasoning it out, then I see a tombstone appearance, a amyloblast, soap bubble appearance. All this put together is a logical or analytical approach. Analytical approach, presenting clinical features, you pick out A, B, C, D, filter through your knowledge, spark of a second, you make disease diagnosis. Whereas analytical process, you rationalize, you present the diagnosis, you rule out, you tease out which are not feasible, then make a diagnosis. And that is the analytical process. The other reasoning process is you pose a hypothesis, deduce or explain or get the reason and provide the reason. And that has problem framing. You develop a hypothesis, gather data, analyze the data, makes a diagnosis, puts into a therapeutic decision. For that, you have three things. Claim. It is an assertion or a conclusion whose merit needs to be established. You assume. Then you have a data, meaning fact to provide for the claim. Warrant is a process, is acquiring a reason to justify the data for claim from the data. For example, a pulpal pain. The patient comes to a dentist with pain. Data, he has dental caries. So he has a pulpitis. So I have a claim of pain and data of caries or pulpitis. So the deducing of the pulpitis causing the swelling and pain is a warrant. So claim, data, claim to data is warrant. Now let us involve this thing. Using a simple example of claim, warrant, data of a pulpitis. The patient comes with the pulpitis, as we said, a swelling and a pain. The patient history says that he has past episodes of sensitivity, not filled a tooth. Now you develop based on that, the patient has something to do with dental caries. That forms the claim for the next hypothesis generation. Yes, he has pulpitis. Now I inquire how long it is there, what is the nature of the pain, everything. That forms, this data forms the claim for inquiry. From that data, yes, it is short-lived, acute. So that kind of, it is chronic, pain on percussion. Yes, these data form the claim. Yes, he has a pain on percussion. The pain is consistent, dull aching. So it is chronic pulpitis. That forms the claim for data analysis. Then I synthesize data, how to treat it. Yes, history of diabetes. Now I do investigations. Radiology, I see a curved root, furcation involvement, together with the history of long-standing dull pain, previous histories of multiple episodes of sensitivity, pain, patient refused treatment at that point of time, has furcation involvement, has large periapical lesion, curved roots at the tooth apical region. Together all this data put together to diagnose, yes, it is a acute exacerbation of a chronic lesion, a phoenix abscess or a periapical cyst or a periapical granuloma. With this claim, I conclude that yes, the prognosis of this teeth is good or bad. And that data, I use it for therapeutic decision. This is how a hypothetical detective reasoning process works. A experienced clinician employs both analytical and non-analytical processes into together to arrive at a diagnosis. A novice only looks for a non-analytical intuitive processing, whereas a very experienced employs both. How? When the patient presents, we look at a pattern process. When you identify a pattern process, you employ a heuristic approach, an intuitive approach, be it radiology or pathology. Look at the radiograph OPG, soap bubble. You have a very limited presentation. You fail to recognize it. Then I go for type 2 processes. You use your intellectual education, training, critical thinking, competence, rationality, feedback, other tests. You put in more questions. Then you say that Based on that, you come to a rational override. You form a working diagnosis. Your rationale says that this diagnosis is feasible or not feasible. If it says it is not feasible, whereas all other evidence suggests that it to be a disease, but something prevents you, and that is you employ a rational override. That is, we said rational override is a clinical decision making literature. It is a system 2 process wherein you override an initial intuitive judgment which occurs to the initial judgment about a patient condition which does not fit into the system until a further new evidence is gathered via your investigation or your elicitation of history. And there is a disrationalization of override where where you make a diagnosis, but something says that it is wrong or right in spite of evidence. So you balance between a rational override and disrational override and come to a diagnosis. You calibrate at last, make a decision, this or that. Why this not? And from that calibration, you make a diagnosis. And this is what an expert does subconsciously over period. Type 1, fraction of a second. Type 2, sit back, think. So what affects the diagnostic decision? Thousands of factors affect your diagnostic decision. From stress, fatigue, physical factors, ergonomics, experience, what you hear, what you read today, cognitive biases, heuristics, lot of things. But the most important is the cognitive biases. We have a lot of cognitive biases, and that by itself are separate factors. People have identified up to 30 plus cognitive errors, or rather, I would say there are more than 3,000 cognitive errors, of which literature says 38 are very important. And I would say that the most frequent are 3 biases. They are the anchoring bias, ascertainment bias, and confirmation bias. What are they? Anchoring biases, you stick on to the first symptoms, finding, and failing to adjust. A cancer patient walks in, gives a history of tobacco, you are judgmental. You make a statement. The cancer is caused by tobacco use. But in fact, it could be genetical component and you fail to elucidate the history. Availability bias, meaning the recent case of couple of OKCs may make you think a dentigerist, clinical dentigerist to be a OKC also. And that is availability bias. That is a clinical diagnosis error. And histopathology often helps to override it. Ascertainment or a stereotype bias. Any white patch in a smoker, first thing is leukoplakia. That is ascertainment or stereotyping bias. You fail to rule out a lichen planus or a lichenoid reaction, which might be the actual cause. So we need to stop and think, make sure these bias do not creep in. Here, the making of a pathologist or radiologist also is important. The degree of inquisitiveness, basically whether they are interested or deprived. There are 2 types. The interested or the inquisitive is curious and eager to learn things, whereas the deprived are indifferent and reluctant. We have to agree that we are either of these 2 or a gray zone between these 2. Seeking feedback. We always seek a feedback to reflect on our performance, to develop ourselves, whereas the deprived characters or the people, tendency people, avoid and do not reflect, do not want to revisit. They don't calibrate, they don't reinvest, they don't perform audits. Here, the system used by the inquisitive, interested people are, they both employ system 1 and 2, whereas the deprived rely on 1 and use less of 2. The acceptance, the inquisitive and the interested people are always uncertain of their knowledge and want to have more information, however insignificant. Whereas the deprived people ignore uncertainty, stick to their initial assumption, more of intuitive or system 1 approach. They are open-minded to alternatives. Inquisitive or interested people are always interested in, whereas the deprived or close-minded, they disagree to alternatives. Mind you, people are in the spectrum of interested to deprived, inquisitive to deprived. And most of us are in the gray zone between these 2 ends of the spectrum. Why this is? Because these control our want. Wanting is the motivation, drive. to obtain a reward of knowledge, of information, of a proper diagnosis. Whereas the liking is the enjoyment of a pleasure, hedonic pleasure of consuming that reward. So I want you to differentiate between a want that is motivational, whereas liking is enjoying the process. Whether you have worked for it or not, you like to enjoy. Wanting money is different from liking money. Why this has a role to play in the inquisitive or the interested and the deprived? Because when there is a novelty and challenge, the interested or the inquisitive pathologist or radiology will have a low wanting but high liking. The deprived will want high wanting and high liking. This makes a difference. Why? Because wanting and liking are two ends of a different spectrum. Wanting employs a dopamine with lot of other area activation. Orbitofrontal cortex, ventral striatum, amygdala, insula, Q silence is pattern recognitions. Whereas liking have more subjective pleasures, working with ventral palladium, not the striatum, and has a different updation. The reward consumption is learning and implementation is different. When you want, you learn, invest more. When you have a liking, you ignore. You see the risk benefit, then only you employ. As I said, wanting has a dopamine path activity, whereas liking has a mu accumulation. The different parts of brains. The wanting or appetite works with amygdala, whereas delight has different pathways. Nucleus accumbens, ventral. The complete brain morphology is different. What does that do? The inquisitive type of character, wanting low, high liking. High want and high liking, D type of deprived types of curiosity. So your brain, how you are inquisitive now. Now let me go to this slide and see if you are having this kind of approach, your novelty challenge is different, and that will affect your system application. A deprived relies on intuitive, whereas inquisitive relies on system 1 and system 2 equally. So this difference, inherent difference, is from your brain pathway. Why this is important? Because ultimately you are putting that into your diagnostic process. It is a neural mechanism that is playing. When I say neural mechanism, our immediate application of today is artificial intelligence. When I say oral cancer, smoker, output, correlated cancer. When I say yes, family history of cancer, why not genetic also plays? Then I ask the age of the patient, 25. Probably genetic component is more. That is the chain of thought prompting. Then we have self-consciously with COT. Yes, when does the patient start smoking? For this 25-year-old female or male, he started at 24 years of age. Therefore, the component is more of genetic rather than tobacco use. So you come to the diagnosis. Whereas the tree of thought puts together all the facts together. Yes, patient age, young age tobacco use. Something is normal. What is the thing? Ask the family history. Immediate family has a history of lot of cancers. Yes, why not be that? Reduced age, family of history of cancers, recent smoking on history. Yes, this chain of teasing out is called as the tree of thought. These together forms the basis of artificial intelligence. Remember, artificial intelligence is trained on data sets. If you have a poor, biased, rich data set, you will create improper artificial intelligence. It will be not useful. But when you develop a proper set-based things, you will be able or harvest or harness artificial intelligence in the best possible way. So this bias also could creep in. Your bias also could creep in. Whatever you have accumulated in the data set will creep in your artificial intelligence. So that is the need of the hour. And moreover, the bias that creeps in, especially the cognitive, could influence your artificial intelligence, could influence your teaching methods, assessment methods. Everywhere this is there. Because a major discrepancy between the breadth and enthusiasm for diagnostic error reduction intervention, but actually in ground level, we don't have actual interventions or evidence for reducing diagnostic accuracy or errors that emanates from system 1 and system 2 errors. Competency is knowledge deficiency is different. That can be corrected by rigorosity. But the system 1 error, how to avoid it? System 2 errors are very difficult to avoid. How to? That comes with scientific approach. You have to understand the neurocognition behind this to address the problem. So what are the error reduction strategies? Kahneman's directive, slow down, ask for reinforcement from system 2. That's a lesson by itself. And you have heuristic based error reduction, which is learned individually, cannot be taught. Knowledge based error reduction, that is where competency, working with discordant features, as Mehmet said. So these are the things that have to be imbibed in the curriculum, imbibed in your practice teaching methods, so that you minimize your system 1 errors by training, system 2 errors by and large. How to avoid cognitive errors? You should be always asking, what are the traps in this particular case that I might fall into? What else can it be? Differential diagnosis, not be blind what your textbook says, but rather apply to the context. Is there any features that doesn't fit? Is there more than one thing going on simultaneously? Am I missing anything? Is this a case where I need to slow down, where I need to employ intuitive or analytical thinking? Thinking this, answering to this to yourself will help to avoid cognitive errors. There are a lot of cognitive bias approach to addiction, may it be anchoring, availability, confirmation, framing, premature closure, heuristic, self-centered. A lot of there are there. We have educational delivery systems, including face-to-face, involving lectures, tutorials, simulations, whatnot. And the number of sessions are single sessions, meaning this is not a rocket science too big. We could use a lot of approachment to correct this. Deep biasing techniques, case-based learning. That is why our competency-based curriculum emphasize, and NDP, NEP emphasize on case-based learning rather than anything else. But when we are evolving this, we have to inculcate or place the correction of bias as our foremost endpoint. Our assessment methods, teaching lesson, learning methods should have or account for these corrections in biases. Now I call upon our previous terms. Now I hope you have understood how all these plays a role in our conscious or subconscious. To summarize the entire presentation, the theoretical and common knowledge position is that the errors in clinical diagnosis and reasoning arise primarily from the type 1 processing and are often corrected by type 2 processing or system approach in dual theory. On the overhead, it looks very simple, but it is not as simple, but involves a lot of neurological training and conditioning. So the simplistic classification could help us to understand the neurological basis of diagnostic errors. We must admit that the errors can arise from both kinds of processing, and predominantly neural process is influenced. So if we are able to correct our metacognitions and as well as the neural process, understand the neural process, we could create better content, learning books or teaching methods, better learning, better assessments. The assumption that most errors are a consequence of cognitive bias alone is wrong. Parallelly and equally, knowledge deficits are also a significant contributor to diagnostic errors. So, addressing the competencies is the need of the hour, and there also need to be strategies to induce some reorganization of knowledge in the newer curriculums or updates so that they can have consistent benefits in terms of reduction of these errors. First of all, our clinical community needs to create or identify the extent of the role of the biases in actual clinical practice in different settings. Even if some of the errors, especially the grave errors associated with mortality and morbidity, arise from cognitive bias, the resolution of errors also involves the application of clinical knowledge, teaching learning assessment methodology, which may underlie the initial mistake. Understanding the neuroscience and the process sequences behind the diagnosis making and diagnostic errors would help to frame better curriculum, better teaching learning methods, clinically relatable competencies, and assessment methods. Ultimately, this will reduce diagnostic errors and benefit the mankind by and large. Thank you for the opportunity. And if you have any queries or suggestions that you need personal clarification from me, you can contact me at these areas. I thanks an opportunity for the opportunity once again. Thank you.
Well, if you have any questions and comments, please remember to put them in the chat. And that was a wonderful presentation on a very new topic that was really very interesting. In the meanwhile, while you get organized to put in your thoughts and your questions, let me bring you the. I was just telling you about the membership. So, first and foremost, what you need to know is even though there is a membership, nothing is going to change as far as the content. Our regular content, which we have been bringing to you, will stay free, will stay available. There are almost 200 videos in the archive, and you can easily and freely access all of it. There's no change at all there. The membership is basically just to help us do some more things and also for you to show how much you love the channel. So there are three categories. The first is the enthusiast, in that you get these pretty little badges. I think already two of our members are there today, so you can see the badges. You will also get custom emojis that you can show, and you get priority reply to comments. Then you get expert. The next level is expert. Of course, there are the perks from the previous um, category, but also what I'm really very, very excited about, and what most of this is going to be supporting, is the video atlas of oral and maxillofacial diseases. This is going to be specially edited lesion wise, so you get, and it's a, of course, a clinical pathological, which means um, you get the clinical images, you get any radiology that is there, and you get histopathology including special stains lesion wise. So very soon you will be able to actually look for a specific lesion and find everything you need. There will also be differential diagnosis, and this is dynamic. Of course, it's very useful, I think, and you can let me know if it's or not. But in my way of thinking, it's very easy in today's world where we don't want to read a lot. We don't want to go and look for 200 different references. So this will be helpful for, of course, making diagnosis when you have tough cases, for teaching, for even for learning, and also even to show patience sometimes. So this is what is going to be available to you, and also you will get member shout outs, which means new members will get a special shout out as they join. The last one is the maestro, and this is for someone who truly truly loves this. So this is all the previous perks, plus we will share your milestones. Let's say you have a publication you are very proud of, you just spoke at a conference you want to share. So we will share and celebrate those through our channels. You get a discount on all our paid events as and when we have it, and you get an exclusive networking event that allows everyone who is a member to meet each other in a specific Zoom meeting, so you can really establish connections with each other. Of course, these prices here are shown now in rupees. From what I have found, I have no real way of checking it, but in all the countries it's available. YouTube will show it in the appropriate currency. And of course, sadly, there will be some countries where it is not available. That really cannot be helped. And yes, so our very first five members, the very first member was Dr. Bhuvan Nagpal, and he is also here today. Thank you. And the subsequent four are Ash 8812. I do not know who that is. and Dr. Vijay Lakshmi. She is also here, Dr. Carla, and Dr. Vivek Gupta. Thank you all so much for being the very first five to join in within a week of the whole membership going online. Although I have actually still not shared it with everyone. Initially, I had only shared it with a few people, so I was very happy that they joined. But now it is open, and frankly, once you go to the channel, you will see a join it. You will be seeing it even right now below the channel's name, and once you click it, you get all these options, and the one that you choose, you can click on the join and you get to join. So that is that. Let us see. Of course, I got to say we have still not got Professor Ruben back. So let's see, have you all got any questions so far? Nothing. Okay, right. So let me chat with you. This is a topic I can chat with you about. I can also tell you this is the book you should read if you are interested in this. And of course, let me share a disclaimer that I am not going to gain anything by you buying this book. But it's a very good book. It's by Professor Daniel Kahneman, and he is a winner of a Nobel Prize. Interestingly, for economics, he wrote this Thinking Fast and Slow for Economics to begin with. But it was about how people make choices in investing, in purchasing. But it has gone on to prove that it's the same choice, the similar kind of choices we make in everything. And it's really very interesting. If you have ever years ago I had when I was teaching, I'll just give you an example what thinking fast and slow can do to you. So I had this student who had just seen a case and very excited came and told me, ma'am, there is a erythroleukoplakia in this patient. And I went and I looked, and as I was going through the quadrants, I actually saw what looked very much like a frank carcinoma. And then I also saw the erythroleukoplakia, not that it wasn't there. And I'm asking the student, erythroleukoplakia, what else? And she was so excited about the erythroleukoplakia. You see, what had happened was, after seeing the erythroleukoplakia in an anterior part and in one quadrant, she had really not gone through the rest of the quadrants in depth because, after all, what are the chances that you will have two lesions in one mouth, right? So, but the chances are there sometimes. And in that case, oh, yes, you're back.
Yes,
So,
ma'am.
in that case, what I found and what I had to explain to her is whatever whatever lesion you may see or whatever you may see, don't jump to a conclusion. There has to be a, like they say, an SOP, a standard operating procedure. It also has to be there for the way you examine a case. You have to, if you're after hearing about the case from the patient, and then you have to actually do the examination going step by step. But our minds and our brains rather are lazy and would like to catch on to that first thing they see. So that is where you land in problem. Instead, better that you take the time and go through the process. That slowing down basically does make your mind switch into system two. But now we have the expert back, so we will let him talk.
Yes, ma'am.
Yes.
System one,
So,
because we are trained, we are exposed to at least say 3 to 4,000 hours of diagnosing and reporting throughout our MDS curriculum, or even more with BDS curriculum. We tend to get to atomicity because 80 percentage of our diagnosis come from less than 10 percentage of our Schaefer or Allen. See, most of the cases we meet are very common, like dental caries, leukoplakia, or periodontitis. Most of the cases. So that bias always confuses, it clouds us,
yes.
and distracts us from the underlying lesions. So we have to come out of that system thinking from one to two, because we
Oh,
see
no.
that in and out, day out. So we are misled often. So probably repetition, thinking, taking a seat back, ensure that we are not making a mistake. Essentially putting across system one to system two kind of thinking
will solve half the problem. Next thing is, in our curriculum we don't have any reinforcement audits or cutting down biases. So I think we are in a stage where we have to consider to create a system where we approach these biases in a more. Am I right, doctor? Audio is cutting down. Hello, my audio, ma'am. Audio.
Sorry, your
Yeah,
audio is fine. Mine
yeah,
was turned off.
yeah.
Okay.
Okay, it's
Okay,
taken a little
yes.
back because of these
Yeah,
issues.
yeah. Yeah, yeah. No, no, no. Mine was on
Okay,
mute.
okay,
Thank you,
ma'am.
Dr.
Any
Malas,
questions?
for telling me that.
Ma'am,
Yes,
it is
yes.
more
Thank you,
very
Dr.
common
Nasir.
with OPMDs. Intra-observer, intra-observer variability could stem from biases.
Yes, that is true. There's of course those biases, and there is also the fact, like you very well mentioned in the beginning of the lecture, is when we are sort of bias ourselves, or rather, where our mind just jumps to the conclusion that's the easiest.
Yeah.
You know.
Yes.
Yes. So that is the thing. Okay, we don't have everyone. Please put in any thoughts and questions you have. Till then, we will just say hello to whoever is here. Of course, we already said hello to Dr. Nasser. But anyway, so Dr. Nasser is with us today. And he's always with us. Thank you so much. And considering he is watching this in the middle of the night, that's really some dedication to oral pathology. Okay, then we have Dr. Nagpal and Dr. Sandhya. Hi, Sandhya. We missed you in the conference. And Dr. Dinkar, who a lot of them I just met in the conference, so that's nice. Dr. Garima, yes, hi. And Dr. Madhura, hi. Dr. Vijay Lakshmi, yes, hello to you too. And Dr. Pushpanjali and Dr. Malaz. So that was hellos to everybody. Of course, Dr. Malaz also was telling me that she couldn't hear me that time. Right. So let's see if we have any other comments. No, apparently nothing. Okay. So, what do you think? If someone wants to go ahead with this and is interested, we have just a couple of minutes before we stop. So, what do you think they should do? Where should they start from?
Start
Beginning.
from, yes, ma'am. Start from introspecting their process. Basically, develop a checklist. Identify their strength, weakness, opportunities, and challenges where it could emanate from. Basically, mindfulness is the key to avoid bias. Think where all these could go wrong, where my PG or my resident could miss the information. Sit back. Uh, Intuition is good, but it should be balanced. It should be based on the evidence. Intuition and evidence should be based. If your intuition says something, listen, but always report by evidence.
Yes.
Intuition may be right, but you are not getting the uh, you are not getting the evidence correctly. You have to search for the evidence.
Evidence,
In
yes.
case your evidence is not coming up, explore before jumping to conclusions. Yes, as Dr. Malas says that
Yes.
we need to train our the brain to work in both systems.
Systems.
Signing out
Yes.
amyloblastoma straightforward OKC has to be system one thinking. But for lesions that has significant morbidity or mortality, we need to take time before we pronounce a sentence or a report.
Very true. Very true. Yes. And this is all very, very interesting. And like we were talking the other day, I think, while we were discussing this lecture, was that this is going to be the basis for updating and upgrading the whole education system and the diagnostic system, which we need to put in place as soon as possible.
Not only that, ma'am, it is a basis of artificial intelligence. The bias we do in reporting will creep into it probably, say, in 5 years or 10 years sometime. We use a wrong data sets to evolve a clinical decision making system. We are
Yes.
creating bias, so we need to be aware where we are, how does it could create an issue, and work into
Yes,
that aspect, and probably create better systems.
that
I
is
know that
true.
it is still a far-fetched dream, but we can at least dream, start
Start
having
dreaming.
a clinical or AI-based reporting system to help us out,
Yes.
not to make diagnosis.
Yes, but this is actually practical and everyday use, not just in practice and not just in diagnosis. But I have seen this happening, say, even in an exam. I'm sure everyone has seen it. You have a student gives one wrong answer in a viva. You tell them that's not the answer, very emphatically. That's not the answer. You give them two choices. So, I mean, you have already cut down their whole span of choices, and the chances of being right is 50% if they choose one of the two. But they will be so stuck on their own answer, even though they know it is wrong, they will repeat the same answer, which
That
is
happens.
something very odd, but it happens. And I think it's the same part of that being stuck on that, the first thing that you choose and your mind refuses to let go of it.
Yeah, there is a dissonance. Your belief system does not work with the fact you fail to accept. That happens with smoking also. A lot of doctors do smoke. They are aware of the ill
Yes,
effects, everything, but their belief system prevents them to accept the fact. So it is
yes,
cognitive dissonance kind of bias that is playing
yes,
in the fullest effort.
that's true.
Very simple day-to-day practice.
Very, very simple and very, very true. Yes, I have to say that is very true. Okay, we have one more that I missed. Our mentor, Dr. Mala, says our mentor used to tell us in pathology it is better to underdiagnose rather than to overdiagnose. Which type of bias do you think she was trying to reduce by giving us such advice?
I would say it is not a simple black and white kind of bias, but uh, this I wouldn't call it as a bias, because without going into the circumstances or the conditions that makes a diagnosis, we could not go into this kind of being judgmental whether over diagnosis or under diagnosis is a bias per se. Giving an accurate diagnosis, because our treatment is going to be based on that. By underdiagnosing, you are keeping your treatment options open. But if you do a overdiagnosis, for example, for a necrotizing myelometaplasia, you go for a en bloc dissection, you cannot undo it. But you underdiagnose it, you can still go back and revisit and do a broader treatment. Probably this is the philosophy that people have been saying, that that it is better to underdiagnosis rather than to overdiagnosis, rather than anchoring this on biases. This could be, I say
Yes,
that this could be a cognitive deficit, competencies, anything. But our process or the context that I have presented this condition is the spot decisions that we make is to put in one step backwards, realize what we are talking or doing and reporting. That is the take
yes,
home message. Before you report it by intuition, answer 5 or 6 checklists whether you develop for your own system, make sure that system 1 and system 2 thinking are in coherence with each other rather than in dissonance. You are able to satisfy yourself before giving a diagnosis rather than, put it in a nutshell, be mindfulness of your reporting.
That is true. And also, I think just going by this, because, like you said, we do not know the context of that whole decision, saying one way or the other would be very difficult and would
Yeah.
be actually us using system one.
Yeah.
Yes. Okay, we have another one. Dr. Madhura says, how does a clinician or a pathologist realize that there is an error in diagnosis unless someone says so?
Doc, we have often in the academic and private reporting system, we always do second opinions or double reporting, as we call it as. When there is a consistency, we believe that two equally competent people cannot make mistakes that easily.
That's true. She also says it's a self-reflection plays a role in addition to conversation with experts.
So
Yes,
when double reporting, it is highly possible that two competent experts makes the same mistakes at the same point of time. So double reporting always solves this problem. At least
that's
one
very
of them
true.
will raise a question. Why not? Because these two people who are equally competent or have a baseline competency questions. So double reporting will help to avoid the biases. That is why our system, what we have evolved, always have double reporting in action always.
That's very true. And I think it will also help if the two people reporting are not aware of what the other person has reported beforehand.
Yeah, most of the institution does it, double reporting. Or even
Yes,
what happens is the residents first see the case, prepare a diagnosis, the mentor goes through all the evidences praised, look at the clinical pictures, look at the histology, then radiology, arrive at a diagnosis before we proceed further.
very true. Yes. And Dr. Maduro also says, thank you for an excellent presentation.
Thank you, thank you. I should thank Dr.
So,
Mandana for encouraging this off the track topics that is relevant, because
thank you.
dermatopathology is full of these kind of bias avoiding literature is coming up. At least 2 to 5% of their literature is coming up with this kind of approaches.
Yes. We need to have standards and we have to, of course, be our own standard. We can't expect others to do it. So, yes, that is essential. Okay, I think we have already shot a little over time. So let's just see. There are no other comments also. And let's just, yes, let me give you your certificate. Thank you so much
Thank you, madam.
for,
Thank you for the opportunity. I thank Professor Ranganathan for the opportunity and recommending me to Dr. Mandana for this topic, which I know that it is very off the beat topic. But still,
yes,
thank you
it
for the
is.
encouragement, and I am surprised that people are asking me doubts on this topic.
Hmm.
I hope I have started a discussion on the theme. Let us be the start.
Yes. Let us be the start. Absolutely. I'm sure we can be. There was something that was supposed to go on but didn't happen. Okay, now it's happening.
Yeah.
Yes,
Thank you,
slight
madam.
delay. You're most welcome. Thank you so much for being with us, for all your efforts. And I must say, I have rarely found anyone in the last 3 years that I've been doing this who has been trying and worked so hard to see that the lecture was interesting and accessible to everybody. So that is really very nice. Yes, I think we have, okay, we have, yes, that's
Yes,
Dr.
that is what.
Madhura says.
Developing a SOP and following it as system two.
Exactly, it's a system too. Yes. And Dr. Malla says, thank you for the very interesting topic. Yes.
Thank
And
you,
thank
madam.
you all for watching. And thank you again for being here. And while you were not there, I showed everybody the book, Thinking Fast and Slow. So in
No,
case
no,
they want to
that
go and
is
get it,
that is the starting point. Economist Nobel
exactly,
Prize.
to
Yeah,
begin with.
yeah,
Yes. So I was just telling them that's where they can
yeah. I
start
saw it,
from.
ma'am. Actually, I saw it. I was
Yeah.
able to see. but
Oh, you could see. I couldn't see.
connection. That's the issue. Okay.
Okay, okay, fine, right. Thank you so much. So,
Thank you, ma'am.
coming to
Pleasure.
what is happening next week, we have Dr. Keith coming back to the channel. He is going to talk on tooth pathology, which is again something we don't really do as much with as we should because, of course, we are oral pathologists and that's where we are. So, pathology from tooth is very important. There's going to be a two-part lecture. The first one is on the 14th, that's next week. The next one is 2 weeks after that. You will, of course, find all the details as usual. And until then, you can in fact put a reminder right now as you're on the channel because it is already there. And with that, the next thing I have to say is have a wonderful time, be well. And if you have not subscribed so far, subscribe to the channel, check it out, be with us, and come back. Be well till next week. Bye. God bless.